Good morning, everyone. Welcome to the first CME for the year 2026. And this is the fifth consecutive year that we are doing the CMEs at Peradeniya. And thank you very much for your participation. And also, I want to thank you all for the last year comments because it helped me to formulate some important topics for you all because you all have told what areas you all need to kind of brush up and improve our knowledge. So today I thought of talking about hemodynamics monitoring, one thing outside the ICU, because in an ICU setup, you have all the equipment, but when you assess a patient in the ward, let's say if you do a pre-operative assessment, you don't have any of the equipment in your hand. So how would you assess a patient and that particular patient's hemodynamic status? So let's see, we'll start from very basics and build up so that you will understand how to assess a patient very simply. Right. So if we look at the first part, basic hemodynamic monitoring outside critical care, it's starting from the bedside assessment. So what we are trying to aim at is, if you can remember from your medical student time, there have been little things that you have learned. We are going to incorporate that physiology and the pathophysiological changes that you have learned into the simple fluid assessments, and also to analyze what sort of a hemodynamic status patient is in. And then you should understand when to give fluid, when to escalate, and when to look for an ICU bed. So if you look at hemodynamics, basically it is the delivery of oxygenated blood into the tissues. And outside the ICU, it should be a very rapid decision, as well as it should be low tech involved, as well as it should be reliable. So let's look at what are the clinical assessments that we can do. And so how can you interpret blood pressure in very simple ways? And how can you look at a multi-para monitor and tell about the ECG, the rhythm, and what is the outcome of it? And then the oxygen saturation and the pulse oximetry, is it only telling about the saturation or is it something else? And also look at the fluid assessment. You can do a fluid responsiveness tests and see the blood gas. And do you only look at the pH? How do you interpret the fluid status by looking at a blood gas? And putting all together, let's see how to give fluids, what to give, and when to escalate. So simple clinical assessment, let's start. So you might think this is first year stuff from the medical school, but starting from the very simple things. So for example, you can start from the peripheries of the patient. So you can touch the patient and see whether there is a warm or a cold periphery. So if it is warm, it is a vasodilated patient. And if you start feeling from bottom to top, you will feel a cold line. So if you feel a cold line, that means there is a warm cold difference. At the same time, there is profound peripheral vasoconstriction giving rise to coldness that you feel. And also that indicates there is some problem with the perfusion. So the patient's peripheral perfusion is less. And also you can see motley. So if you have late to detect the hypotension and the hypoperfusion, then you will see skin motley. And also there will be a peripheral temperature gradient. So if you look at if you touch the hands and if you touch the trunk, you will feel the trunk is more warm than the hands and the limbs. So it's an indicator of shock. So you can say the patient is in a hypovolemic shock. And also if the patient is having clammy extremities, you can say it is a cardiogenic shock, where you might feel slightly sweaty hands, and patient is little moist also at the same time. So that is a feature of heart failure in addition to the hypovolemia, right? And then if you have facilities, you can compare the core to peripheral ratio. So if you have a way, let's say if there's a nasopharyngeal replaced temperature probe, or if you can do a tympanic membrane assessment and then assess the peripheral perfusion, so there will be a core to peripheral ratio. So that also shows that there is a underperfusion to the peripheries, which is another indicator of hypovolemia. So if you look at the simple clinical assessments again, the capillary refilling time. So we all know to press it for 5 seconds on the nail bed and to release it. So again, that is a very important indicator of poor peripheral perfusion. So in some studies, actually, in this one of these Andromeda shock trial, there's trial 1 and trial 2, where they have found out, they have compared the validity of capillary refilling time versus other parameters, like they have done some hemodynamic assessment. But then they have found prolonged capillary refilling time was quite reassuring to diagnose the hypervolemic shock or the underperfusion. So, I mean, it is a very good news for us because we don't have much facilities. So, we have the simple bedside assessment where you can assess the capillary refilling time. So, always make sure you reassess the capillary refilling time to look for the response for the fluid that you administer. Right, so it is very easy. Even during surgery, also you can do the same. You would have seen when you anesthetize a patient, when you give a general anesthesia, sometimes it's very difficult to cannulate also because the veins look very small. But just notice when you give general anesthesia after a little time, you will see the veins are quite large and distended because there is a vasodilatation anyhow because of general anesthesia. But after a little time, because it gets equilibrated, again the patient can go into the same shock situation where he was. That is why you get a sudden blood pressure drop soon after the GA, and then later on, again, you will see the patient is somehow reaching the homeostasis. So that is the time where you can recheck your capillary refilling time. If it is a child, use the sternum. If it is an adult, use the nail bed. So if your patient is very awake and if they are very sensitive to pain, you can imagine if you touch the nail bed, it's very painful. So sometimes it is recommended to touch the other side of the nail. I mean, that is the palm, you call the fingerprint area, right? So there you can sometimes in research they do press with a kind of a glass slide so that you can see it very clearly. Or else you can press on the other side of the finger and look for the capillary refilling. So that is a way that you can assess your patient's hypervolemic status. So if you look at the other parameters, the pulse character. So very simply, look for the bounding pulse. It is vasodilatation, could be sepsis, carbon dioxide retention. If it is a 3D pulse, can be low stroke volumes, bleeding, dehydration, obviously. And alternative pulses like pulses paradoxus, suspecting tamponade, maybe asthma, and also LV failure if you have a pulsus alterans. So collapsing pulse such as in thyrotoxicosis, AR patients, and it is not shock, but you need to understand what type of shock it is because we have 4 types of shock: hypovolemic, distributive, cardiogenic, and what is the other one? Anaphylaxis is distributive, cardiogenic, hypovolemic, uh, so neurogenic shock. Yes, neurogenic shock. So you can differentiate what type of shock it is. So if you see a patient who is, sometimes you all present us, this patient looks like thyrotoxic just before thyroidectomy. So you can look for the collapsing pulse. You hold the pulse from the heel of your palm here, and then sort of you, not from the fingertips, because fingertips are already sensitive to the pulse sensation. So you have to hold from the heel of the palm and hold the pulse and raise it. So then if there is a boundingness, you will feel it here because this area is less sensitive to pulse. Then you are able to feel it. So that is the idea. If you feel from the tips, it is anyway sensitive because we have been feeling for pulse for many years since the day you became a student, medical student. So there you might not be able to feel the difference. So that is important to check. And then if you look at the blood pressures, you can see the systolic blood pressure. The peak LV output is a direct indicator by the systolic blood pressure. So if your blood pressure is low, the systolic number, suspect whether the LV is not properly contracting or not. So as a bedside thing, nowadays you all have ultrasound in our facility most of the time. So use the echo probe, keep at the LV, just go to the left side of the chest and have a look at the heart. So it is very simple because you can, I mean, if you go on doing that, you will realize that you also can eyeball and assess the left ventricle. Even during surgery, let's say if it is a lower body involving surgery, if you have access to the chest, if you have a suspicion during surgery, please take the ultrasound scan and keep the probe and see. Because that will guide you to start on inotrope if you see a significant LV undercontractility. So that picture will correlate with your inotrope use, because otherwise we just start on inotrope, we haven't seen the heart actually, right? So try to do those because then that is useful. Then if you look at the diastolic blood pressure, mostly it is because of the vascular tone. So if you see a low diastolic blood pressure, that is because of peripheral vasodilatation, and that will ultimately affect the mean arterial pressure. So if the mean arterial pressure is low, the coronary perfusion is also going to be low because coronaries are perfused during diastole. And also you can see the equation how you derive mean arterial pressure. And so diastolic blood pressure is a determinant of mean arterial blood pressure. And our target should be more than 65 for adequate organ perfusion. It is a practical target that we need to maintain. So another important thing is, again, the blood pressures. Let's say, for example, if you have isolated low diastolic blood pressure, it could be a sepsis and a vasodilatation. Commonest example is your amputations that you take into the theater. Low pulse pressures like tamponade shock, low stroke volumes, and high blood pulse pressures like aortic regurgitation, high output states. So if you look at this sort of a mean arterial pressure, so it shows that there is low perfusion. And if the mean arterial pressure is 93 but narrow pulse pressure, again, you can say there is low stroke volume even at this blood pressure, because the narrow pulse pressure that is shown as 100 by 90, the difference is only 10. Let's look at the multiparameter. So we always kind of connect the patient to the multiparameter. As anesthetists and intensive care doctors, we always look at the ECG. So again, simple things, look at the rate, rhythm, and look for any irregularities, QRS width. So basic ECG needs to be like learned and recapped all the time. And also you can see the electrical mechanical dissociation signs if there's any heart blocks, and also look for features of tamponade. For example, tachycardia, elevated jugular venous pressure. So whatever you see, try to correlate with the clinical signs and see whether you can pick up what is going on. And then look at the low voltage QRS complexes, narrow pulse pressures, especially like hypotension. And if there is hypotension, tachycardia with distended neck veins, so your highest suspicion is tamponade. So the commonest example that you get in the hospital is your trauma patients who are coming after high velocity road traffic accidents, seatbelt injuries, and sometimes you might get, there was a patient with pericardial effusion who was hypoalbinemic or hypothyroid in dental ICU, I think once there was a patient with pericardial effusion. So likewise, there will be patients. So what is the commonest ventricle that will get affected when there is a tamponade? It is the right ventricle. The reason is the thickness is very small. It is less muscular. So the chance of collapsing is more on the right side, because LV somehow will maintain because it has a thick muscle wall, whereas RV can collapse very quickly. So next very simple assessment is the bedside passive leg raise test. So these are very easy tests that you all can do. The way to do is you can keep the patient first supine or slightly 30-degree recumbent position, and you explain the patient what we are going to do, exclude any obvious heart failures, and then you are going to raise the legs 45 degrees up. So before you do that, you note down the blood pressure, the systolic blood pressure, and the heart rate. And what you expect is when you raise the legs, you give about 300 milliliter of blood from the legs. So in an average person, which is known as auto transfusion. So you give this bolus and there is a transient period and you are looking for a pulse and blood pressure change. So the accepted response is you will be seeing a drop in the pulse rate and a rise in systolic blood pressure. So if there's a rise of 20%, of the systolic blood pressure, let's say your systolic was 80 when you started, and if you get it to 100 after leg raise, so that means there's a volume response. If your heart rate was 100 before raising, and if it's coming down to 80, again there is a response. So likewise, that is a positive response, then you are allowed to give fluid. So whenever you are in doubt, that can be done, and you can decide whether this patient is volume responsive or not. So at the same time, you can amalgamate with the IVC assessment. So if you can hold the probe and if your assisting team can help you to raise the legs, you can assess the IVC at the same time and look for the distension of the diameter, so that it is easy way for you all to decide whether there is volume response or not. So then it is useful outside the ICU again, because you don't have much of monitoring facilities. So that is the idea. So it is very easy for you all to do. So you will see the systolic rise or the pulse pressure rise and a drop in heart rate. So there is another indicator I think some of you all already using, which is known as the pulse index, PI, which is next to the pulse oximeter value, right? And it is written as P and simple I, or PI in capital letters, which is shown as a index. So this is the perfusion index. So when you look at the pulse oximeter, there's a thing called the perfusion index. The usual range is from 0.2 to 0.2 to 20. So it comes as that. So if it is anything less than 0.2, now here it is 0.13 in this monitor. So that is an indicator of poor volume to the peripheries, right? So again, the pulse oximeter is also giving you a very little number, which we don't usually, detect. So I also learned it very recently, about a year ago. So that is also an indicator for you all to see that there is a volume response. So that is a perfusion index. And also, if you look at the pulse oximeter waveform, you all know it is usually kind of a blue color waveform or any color waveform that is appearing on the monitor. So if a patient is spontaneously breathing, sometimes you see a bit of a wavy alteration of the baseline, because during inspiration, there's a negative intrathoracic pressure. So because of that negativity, there is a lot of venous return happening. So, and then during expiration, there is a positive intrathoracic pressure. So because of that, again, um, there is a pressure difference. So with that, you might see a kind of a waveform alteration of the pulse oximeter. So that is an indicator, again, there is a volume gap. If there's no much alteration with breathing, probably the patient is well filled. So next time you do it and see, ask the patient to take a deep breath, especially who is fasted coming into the theater. Just have a look at the pulse oximeter quietly and see whether you see a massive kind of a swing. So that is also an indicator that the patient is under volume. Right, so very simple things you can use. So pulse oximeter is everywhere. So that is another kind of a monitor that you can use to guide your fluids. So you give your fluid, look at the PI again, look at the waveform plate. So you know the arterial waveform that we reduce the wavelength and have a look. If have you all seen the sweep that we alter? So usual running speed is 25 millimeters per second. But if you make it to 6.25 millimeters per second, you see the arterial waveforms close by. So same thing you can do to the pulse oximeter wave also, where you can reduce the sweep and make it more closer so that your comparison is easier. So you can see about two breath attempts in the same monitor screen. So that is the idea, so that you can see the pattern of alteration with breathing. So again, coming to the familiars, I think all of you all are familiar with IVC assessment now. And so the location is here, subsiphisternum, and you can either keep horizontal or vertical, and you get the IVC diameters at the where the hepatic vein is branching and getting the tributary into the IVC, and you can look for the collapsibility in hypovolemia in spontaneously breathing patients and distensibility index in mechanically ventilated, positive pressure ventilated patients. And the non-collapsing IVC will show the patient's volume status, could be a right heart failure as well. So your challenge is to turn the probe slightly towards the heart and have a look at the right heart also at the same time. Right? You can look at the four-chamber view from the subsiphisternum level. So those are basic ultrasound. So we all have to do. We can't wait for a cardiologist to come and do the scans for us. And then the respiratory variation you should be seeing during inspiration. So you can see there is spontaneous breathing. The inspiration is, you will see a collapsing IVC. So how you do it is you get the best position to scan, and then you hold the probe there, press on the M mode on the monitor, and then you will get the variability. So you keep the probe there, and once you get the best kind of variability picture, you freeze it, and then you can scroll with the scroll button, and then scroll and get the maximum diameter, minimal diameter, and you get the index, right? So that is how you do it. So then you can see this sort of a diagram where you will see the collapsibility and the distensibility of the IVC, right? So those are very simple things we all should be able to do. And if you have any doubt, so next time when you present also, your presentation will be like this. I mean, when you do your pre-op assessment, so his pulse index is this much. Let's say intra-op, if you tell like this is the volume status, you can tell about your PI. perfusion index is this much, and the echo, you can say, I just had a look at the LV. LV is not very good contracting. The systolic blood pressure is 90. So your next call will be something like that to us, I guess. Right. So that is my idea. So we need to kind of go to a next level. Right. So we can't be doing in 2023 what we were doing. We cannot continue in 2026. So our level should be elevated to a better care. Okay. And that will actually, let's say if you do an interview for an overseas job, if they ask as an anesthetist, what do you do during intraoperative period? So you can smartly say, these are the things I measure. So then you will get extra marks, I'm sure, and you can opt for a better job. Right. So then this is how you look at it, and you can see spontaneous breathing, and this is the positive pressure ventilation. So this is either a hypervolemic patient or a normovolemic patient. You don't see a collapsing, and in hypovolemia, in a positive pressure ventilation, you will see a inspiratory and expiratory difference. So that is how you do it. And then if you look at, so if you put all the things together, how do you decide how much fluid to give and when to escalate? So you know about the warm shock, like in sepsis, you will feel the peripheries are very bounding. So you would have done all this, you would have given fluids if you have cold peripheries, if you have prolonged capillary refilling time, low pulse pressures, and collapsible IVC, and if you have a passive leg raise response, you would have given easily fluid and you can reassess. But let's say if you don't have those, and if you don't see those changes, there is a warm shock in sepsis. Let's say you don't have poor peripheral perfusion, there's bounding pulse, no response to passive leg raise test, and the IVC is also not collapsible. It looks full, but still the patient's blood pressure is low. And if you cannot see any tamponade signs either, then your blood gas might help you. So let's see how you can interpret a blood gas. So it is not only the pH, it is not only the carbon dioxide and the oxygenation, but you have to look at the base excess and the lactate levels. So whenever there is poor perfusion, you will have anaerobic metabolism happening in the tissues. That is why you see a lactate rise. At the same time, because of this lactate, there will be a lactic acidosis. So the pH is going towards acidic side. So then what happens is your first buffer is the bicarbonate is getting depleted for this H pluses. So then you will have a low bicarbonate and there will be a negative base excess. So you look at this, that is why we ask for a blood gas during surgery, especially in a bleeding patient, because we want to get a better idea about our volume status by doing a blood gas. It is not only to look at the hemoglobin, not only for the electrolytes, not only for the perfusion of oxygen and carbon dioxide. It is for the volume status. So it is a marker of volume response that you use during surgery. Let's have a close look about the arterial blood gases. So if you look at our arterial blood gas, so it has it shows the oxygen delivery. So in hemodynamic disturbances, you have a disturbed oxygen delivery, and then there is anaerobic metabolism going on, right? So you will see there is low pH acidosis due to lactic acidosis, low perfusion, cellular hypoxia, and so blood and oxygen is not reaching the tissues. So this is the basic biochemistry we learned, and because of this metabolic acidosis, so there is a low bicarbonate and your base excess is becoming more negative. So there's no excess bases, you are becoming more negative and negative. So that is a situation where you have to resuscitate. So it can be any shock. So that is the problem. So it could be even a cardiogenic shock. So there you need to identify whether it is a cardiac originating one or is it really due to hypovolemia or sepsis. So echo you might have to combine together, and also you will have to look at the volume response while giving fluid and repeating the blood gases timely. So your timing, we cannot say, okay, you have to do 2 hours or you have to do 30 minutes. It depends on the patient. So you have to decide on the patient, and you have to discuss and see whether are we going to do it 2 hours. So you also feel that, because when you do blood gases, you know the next one should not be done that fast, or there won't be a change that soon, right? So likewise, you can think about like that. So clinical takeaway from this is you have to look at the metabolic acidosis. So suspect whether there is poor peripheral perfusion, whether there is circulation is not happening, and there is cellular hypoxia. So that is the situation where you get metabolic acidosis. right? So it is one of the most sensitive blood gas marker is the high lactate level, and it shows the tissue hypoperfusion and the anaerobic metabolism. So there will be a lot of causes. It could be a tamponade, obstruction, sepsis, severe anemia, failure of oxygen utilization. There can be a mitochondrial dysfunction and shock of all types. And also there are other findings. So there is, if you see an improvement, you will see the lactates dropping. So that is an indicator that your perfusion is restoring. And also the next parameter is the base excess. So if there is a negative base excess on the blood gas, that means there is increasing metabolic acidosis. So your bases are getting more and more depleted. So when we see the bicarbonates going down to like 15 with a base excess of minus 12, 13 or so on, we are tempted to give some bicarbonate because we are wanting to keep the patient temporarily mopped up with this acidosis. Otherwise, his cardiac function deteriorates sometimes. Or even though you start on inotropes intraoperatively or in the ICUs, you will not see a blood pressure rise. Then suspect whether there is acidosis. So whenever there is acidosis, the enzymes doesn't like to work in acidic environment. They want the physiological pH range. So they just go haywire, and then you will not see the expected outcome. So sometimes you will see a pattern like this with an acidosis and a bicarbonate of 17, base excess of minus 8. So you know that you are heading for a tissue hypoxia, right? So that is why we do a blood gas to find out the hemodynamic status. And then the high bicarbonates. So sometimes you might see a paradoxical high bicarbonate in COPD like carbon dioxide retainers, where they have got into high bicarbonate level. So then your assessment will be little tricky, because although they become peripherally underperfused, you might not see a low bicarbonate level because they have been chronic retainers. So then again, you have to guide by your rest of the assessments. So think about starting from the very simples like capillary refilling time and all that we discussed. That will help you to decide where your patient is. So the idea is never go by the bicarbonate only, because if you go by bicarbonate only, you might miss the volume status. So don't try to be, I mean, you cannot say you can only do one investigation and rely on that. Sorry. Right. So then, yeah, so that is how you look at a blood gas. So you might have mottled patients sometimes. So mottling is again due to peripheral hypoxia. You will see the skin color changed, and so there will be life-threatening perfusion failures. So sometimes when you detect a mottled patient, especially the amputations that you get in casualties, it may be too late for you all to decide and kind of resuscitate and send back to the ward. So there you will have to definitely look for an ICU bed, and you might have to escalate the care. You have to go for a central line. Sometimes, if needed, have to go for an arterial line if you need beat-to-beat blood pressure monitoring. And you might have to start on bicarbonate infusions. If it is not helping, might have to go even for renal replacement therapy if the patient does not have any good urine output. So if you look at the connections, you can see whenever there is poor perfusion, so there is diffusion, the delivery of oxygen is also dropping, and there is worsening anaerobic metabolism, and then there is lactic acidosis and worsening shock. So this becomes a vicious cycle, and with time it will worsen and worsen. So these are some of the bedside correlations that you can again have a look at. So remember, we'll go with the simple things. So next time when we hear a presentation from you all about a patient, probably we might hear there's cold peripheries, the capillary refilling time is more than 3 seconds prolonged, and there is a narrow pulse pressure on the patient, and the lactate on the blood gas, HO has done 1, the lactate is 6, and the base excess is this much. So probably that will be your fluid assessment next time when we hear your when you call us about a patient, right? So then other than that, so we are getting little advanced. I mean, when you compare from 2021 to 26, now we have got some modern monitors, especially the Theatre 3 anesthesia machine with the Benevision N17 monitor. So one of the most recent or the most advanced monitors in the country we have got. So it has the Edwards Life Science module here, which is the flow track module, right? And also we have this also at the same time. We'll talk about awareness on another day. So this is a flow track module that you have got, and this is the kind of screen that you can get when you use it. So try and use this. We have some transducers with us in the ICU, which you can use. So you can connect it here. And the prerequisite is you need an arterial line. I think the last time the team would have demonstrated that to you as well. So this monitor is available for us. We need to use them for patients where we anticipate bleeding, blood loss. And so you can get the cardiac output readings, the stroke volume index, and the stroke volume variation, and the systemic vascular resistance index, which will guide you on vasopressors. This will guide you on your inotropes, where you are going to use to contract the left ventricle. So the more you increase your inotrope, you will see the SVI rising. The more you increase your noradrenaline, you will see the SVRI going up. Indexes always come for patients' body surface area or to the weight and height calculation. So it is very, very specific for this particular patient. If you go with SVR, that is a generalized number, so your range is kind of narrow. So it is usually from 1000 to 1500. Like if you go to SVRI, you might get a broader normal range. So if you touch on this, you will see the normal ranges of that particular patient, right? So that is how it is. And stroke volume variation, if it is more than 15%, again, a feature of volume, under volume state, and you can kind of fill your patient and see for the volume response. So likewise, we'll use this. Now it is available since it is there at Theatre 3, right? So then the next monitor that we have is the PICO. So this is pulse index cardiac output monitor that we have. So we use the thermodilution technique. It is incorporated into a Philips monitor. It is at the moment living in the ICU, always plugged in and charging. So it is little invasive. You need two lines, femoral arterial line and a central line, central venous line, where you use it for calibration with cold saline, 0 centigrade. And then you have a femoral arterial line where you use it for the arterial waveform capturing, and all these are being taken out from a module. So this is the kind of assembly. So because we take this out rarely, so because we use it for selective patients, because you need to go for invasive femoral line also. We don't use it for each and every patient. One thing is it is expensive, and sometimes we can manage with the minimally invasive equipment. So remember the setting. So you put a femoral arterial line and you connect it into the thermistor. This is the temperature sensing probe, which takes into this main box here. And then you have the arterial line, which comes through a transducer. And then it is being connected to a pressurizing bag, and it is taken back to the monitor through a separate transducer. And then you have the cold line where you get the comparison. You get the cold saline and you check the temperature here, 0, how much temperature rise. So that is calculated as a thermodilution technique on the monitor. This is the graph you get, and the area under the curve is giving the cardiac output parameters. And this is the cardiac output, cardiac index, and then many other parameters you can get from that. And you can derive a separate box with all these information, and this is the cardiac index, cardiac output. So all these are shown on the monitor, and you can decide on more parameters that you can derive, like the lung water index, again showing how wet your lung is, whether you have overhydrated and wetted your lungs. So then you can come down on the volume, right? So likewise, you can decide on the parameters that you are going to monitor. So the next one that we have is the LIDCO Rapid. So you have to be very proud. Hope you all can hear me. So there was a small interruption. Hope you all can hear me. Sorry, there was an interruption in the internet. Right. So we are at, let me just share the screen. So hope you all can see the screen. So we are at LIDCO now. So LIDCO is which is available for us in the hospital. Again, it is a kind of arterial line, through an arterial line, we take the input, and there is a processor, and then it is given as derived numbers on the screen, and this is LIDCO rapid. LIDCO rapid means we don't use lithium dilution techniques. It is by the arterial waveform analysis, we are deriving these numbers. So that is, again, you can see the Starling curve and how the volume response is happening. So when you give volume, you can see the numbers rising and also it is dropping. So there are a lot of numbers coming up here. You can see the volume response, the preload response and all that. So the next important thing that we can do is, we cannot say we don't have, because we always have the ultrasound. So even during a surgery, if you have access to the heart, you can use the probe, echo probe, slowly onto the mid-axillary line of the left side, and you can keep the echo probe and have a look. So if you are in doubt, let's say a pelvic surgery going on, and all of a sudden you suspected whether there is a pulmonary embolism. So you should be able to take the short axis view at here, and then if you rotate it, you can get the right ventricular outflow tract, the main pulmonary trunk, and the right and left. I think I have shown once in the ICU or somewhere, or in the theater to your eyes. So then we'll do that. So, I mean, if one person knows it, next time teach another person, so it will like register in your mind. So keep on doing this, then your kind of skills also goes on, and you get the real picture of the patient, and it's quite fascinating to see what happens when you do something to the patient, what happens to his heart and all that, right? So it is very important to see, because in a rush, if you had to see a pulmonary embolism intra-op, this is a easy way that you can see, especially if you can get the access to the thorax. Right. So we talked about a little bit of arterial blood gas assessing already. So that's all actually what I had to tell. And also, so the key messages is, I just want you all to take all these simple clinical markers first, and kind of assess your patient better, and it will make your life also easier. And you can guide the HOs how to resuscitate the patient before coming into the theater, how to resuscitate the patient before coming into the ICU if you give outreach care, right? Even in the ED, you can do the same. Then use the pulse oximeter, not only for the saturation, for the others also. Look at the perfusion index and do the passive leg brace test for selected patients. Look at the fluid response, and then the use of ultrasound as much as possible. So be a fan of ultrasound. So then you will see a lot of things with that, and also know when to call the ICU. So your escalation will also be very easy if you assess the patient like this, and don't hesitate to ask for a blood gas, because there's another type of shock they describe nowadays in articles, that is called the cryptic shock. So that is because before even you detect it as a hypovolemic shock with high lactates and all that. So sometimes the blood pressure is normal, but if you do a blood gas, you will see the lactate is rising and there is a slight derangement in the bicarbonate. Still the pH is holding on. Still the pH is normal. Still the blood pressure is normal. You will not see a tachycardia also. Sometimes you say in young patients, you don't see a tachycardia. And all of a sudden they collapsed and they crashed, you say. Like especially in trauma, post-casualty surgeries, you say the patient was really good. He was doing all fine. Blood pressure was pristine. That's how the surgical registrars sometimes they say, isn't it? So they say the heart rate was so pristine, there was not even a tachycardia. But then the moment they crash, it's very difficult to take them back. Usually they go into asystole, right? So that is another situation where your blood gas comes very handy, right? So thank you very much. So this is our team. And so let's move forward and see whether we can add those things to our practice. Okay. Thank you very much.